What is, I'll talk to you later about that. So here we are. We're going to go through what our objectives are: to know the relationship between health equity, health literacy, and the structural and social determinants of health; to understand the definitions and approach to health literacy; to recognize the stakeholders who play a role in health literacy in the district; and to clarify your role in these efforts. And I think what we really want to ensure that we all understand where we are, what we're trying to do, and why we're trying to do it. So first and foremost, I want to unpack the key terms and how we use them. We have frequently used this image to communicate what we actually mean by health equity versus equality. Now, what we're seeing here are three kids. They're all of different heights, but the goal of what they're all trying to do is to see the game and participate. So it makes little sense to just give each kid the same box and expect that, which would be equality, to expect that to solve the problem and increase the outcomes, right? So what we do on the equity side is we look at what each of the kids need to be able to participate in the games, because that is our objective, that is our outcome. So this is just to very simply communicate what we mean by those things. So how we frame health at DC Health and for the district is we think of it in terms of a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. That means that this is what our vision is for every single resident in the district: a complete state of physical, mental, and social well-being, and not just talking about being sick or promoting sick care when they become sick. So what is equity in healthcare? Here I'm going to unpack the definitions. A full definition includes all of these words on this page, right? So the first thing that I've put in red is narrowly described: health equity is the attainment of the highest level of health for all people. But to get to that, we have to do some things that are changing how we have traditionally approached health, not only in the district, but across the country. To achieve health equity, we have to value everyone equally, but with focused and ongoing societal effort, right? So it's not just about Anita or Kimmy or Leah working on our own personal health literacy. It's an all of us, everybody's work to address avoidable inequalities, historical and contemporary injustices, as well as the elimination of health and healthcare disparities. So frequently across the US, we talk about health disparities as if health disparities will magically go away if we measure them. What we actually have to do is address the inequities and the historic and contemporary injustices. So we still have more. What is a health disparity? It's a particular type of health difference that is closely linked with social, economic, and environmental disadvantage, right? So we're not talking about traditional health care narrowly described. Health disparities are adversely affect groups of people who have systematically experienced greater obstacles to health. And that's usually based on their race, their ethnic group, their religion, their socioeconomic status, and all of the things that are listed there. But they're really frequently related to historic discrimination and exclusion, right? So when we're talking about health equity, we're talking about addressing all of those isms that we have for a long time say they exist, pretend that we've solved them, but we still have them sitting there beside all of the work that we try to do. So what this means is that we have to more deliberately address them. So a quick summary after all of those words: what is a health inequity? It's, and you know, we don't have official definitions, but this is from the research: differences in health outcomes that are systemic, avoidable, unnecessary, unfair, and unjust, right? So that should be how we distill it. We don't just say, well, everybody has high blood pressure, therefore, hey, doesn't matter. We're looking to see what those differences are and how they might be rooted in these systemic avoidable. And I think that's what we want to underscore. They are avoidable. They are not natural. And then what is health equity in a more summarized form? Health equity is the assurance of conditions of optimal health for all people, and that we focus on rectifying historical injustice and providing resources according to need. So these two terms, when we say health equity and we talk about health, you'll hear me more often talk about health inequities, because that's really what we have to focus on, right? It's not about I'm 5 foot and Leah is 6 foot or whatever. That's just a difference in height, right? That's not necessarily an inequity. It could be, but for the most part, it's not. So that's not what we're looking at. The things that we should all, when we think of health as a human right, we should all have equitable outcomes in relation to what our genes already prescribe. So having said all of that, here we are with a knowledge check. Any questions? First and foremost, turn on your camera or unmute yourself and ask a question. And I guess the actual question is, what is the difference between health disparities and health equity? So when we talk about social determinants of health, this graphic right here is very helpful, right? We talk about social determinants of health, and I venture to say in the American context, we think about this, and this is the formal definition: the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning, as well as quality of life outcomes and risks. So what is this? What this is really saying is that each of us individually, collectively, families, whether we want to think about it as a family, as a community, as people in X neighborhood or a particular ward, are living in a context that to some extent, but for the most part, they have little to no control of, right? So when we're talking about my quality of life and my risks, it's really about the circumstances in which I live, the schools that are in my neighborhood, the grocery stores that are nearby. I am not fully in control of those things, but those things are what we refer to as the social determinants of health. If we think about it, we can see that the social determinants of health might contribute to the causes of our individual health and well-being. But really and truly, what we see in these percentages that we see as to what drives our health are ultimately caused by what we would call the causes of the causes, right? So the kind of healthcare that we have in the US generally, and the kinds of healthcare and the rules of the road, et cetera, in the District of Columbia are really created by our history, the laws that we have. Not every city in the US has special resources for immigrant populations or those kinds of things, right? We know that we're in a current political environment where there's a lot of difference in terms of what DC does and what our values are compared to other parts of the city, or what the rules are. We may have a general umbrella, but we have specific things that happen here in the district. And so we have the Alliance. The Alliance has been here in the district before the Affordable Care Act. We're still continuing with that, but that is a good example of how we could have a unique resource in the district that is more serviceable and accessible here. But what I really wanted to point out here is, while we frequently hear people talk about the social determinants of health, the social determinants of health may vary across the city. So if we talk about grocery stores, we may have 6 full service grocery stores in some neighborhoods and wards of the city, but we may have 1 or almost none in others, right? So that's what we mean by the causes of the causes, and it really comes down to history and values and policy. So bottom line is 80% of what drives our our health in a city has nothing to do with our access to healthcare. We've spent 100+ years in America talking about access to healthcare, and we know the Affordable Care Act is fabulous, but it hasn't magically made us all equitably healthy, and we still have significant challenges and differential outcomes. So that 80%, those social and structural determinants of health are really critical as we move forward. And so here are a summary 6 key insights that the research tells us in terms of, and research just means science, what we know. This is not, I'm not making this up. Dr. Varga is not making this up. None of us are making this up. We have the data and the evidence to show it. Health is more than healthcare, as evidenced by, we fondly call this the donut, right? Health inequities are neither natural nor inevitable. 99+% of all of our genes are the same, despite what we may look like, right? Despite how long we live, our genes are pretty much the same. There's a small percentage that are not. Your zip code may be more important than your genetic code for health. The choices you make are shaped by the choices you have. So whether the doctor says go exercise, eat healthier food, you may not have a full service grocery store within easy access in your neighborhood. And even if it were there, you may not have, or some of your clients and friends and family may not have enough resources to buy the most healthy food that's available. So that's what we mean by the choices you make are shaped by the choices you have. Structural racism acts as a force in the distribution of opportunities for health. And ultimately, what we're really saying is that all policy is health policy. How that kind of shows up for all of us and what we documented in our health equity report was through this lens of what we call 9 key drivers of health and differential opportunities for health in the district. So what you're seeing there is a diagram that's showing education, employment, income, housing, transportation, food, medical care, outdoor environment, and community safety. Those are not the only things, but those are the big things that we know are driving individual and collective outcomes, right? So they have interrelated pathways. For example, if you don't have a good school, you probably won't get a good job. And without a good job, you won't have enough money and funds to fund all the rest of your life and existence, right? So we know we have 21 years difference in life expectancy at birth. We know that opportunities for health vary across the city, where we have a lot of resources, positive, we have better outcomes, and the opposite is also true. And then finally, what we have been able to show is that there are differential opportunities for health in the district by income, place, and race. And so I think we've talked about the health equity report before. Let me just go back. But I invite you, if you haven't seen it, to take a look at that. We're doing more work to integrate some of these data sets, but that is, and this is not unlike what is happening in many other cities in the country. So we've gone through a pandemic, and most of you have been partners with us or somewhere in the process of working with us during the pandemic. So all those 9 key drivers that we talked about are still pertinent. But what we observed during the pandemic was that there were several areas that in the what we call the post-pandemic context, we really need to pay additional attention to. Of course, we know there's access to quality healthcare, but the 20-80% that I talked about earlier still applies. So I'm not saying that healthcare isn't important. We're saying that there are other things that need to be supportive of people's access to quality healthcare, but quality is the key. We have structural and institutional racism, as we noticed from the outcomes. And then we have this part here, which we know that all of you, we deliberately went out and tried to engage structural, social and structural partners like yourselves who really are working beyond the traditional scope of public health, of healthcare, right? I know we now have La Clinica who has joined our team, and we're really excited to kind of do some of that work. But for the most part, during the period of this grant, we have been engaging what we call non-health community CBOs, right? And that is why I'm circling this, is to really let you know that we think you have a unique and critical role to add to the discussion in that 80% period that we talked about. So here we are again at knowledge check. Any questions generally? And then let me, by thumbs up or thumbs down, is this kind of making sense? And am I going too fast or too slow? Let me ask that. Let's see, Edrin has a, thank you, Edrin. And then I'm now going to ask the question, what are some social and structural determinants that your organization addresses? But law was in that column on the right-hand side in terms of the structural determinants of health. And then what Leah read out was about capital area food bank serving seniors. That means that some of you not only know about health, about food and food insecurity, but you actually know something about the elder population in the city, right? So you know much better than we do, as in a practical sense, who these folks are, what their unique challenges are, and how to effectively reach and serve them. And that's what your partnership brings to this work that we could not do on our own. So I really wanted to, cheer all of you in the work that you do, and to really underscore that you are actually doing the work, right? And I'm saying we public health are the beneficiaries as we go forward. So I'm going to go to the next slide. So now I'm really going to go into what is this thing we're calling health literacy? What's this new definition, and what the real world applications and opportunities are as we go forward, not only for the remainder of this grant period, but in terms of our ongoing collaboration beyond the grant itself. So health literacy can be defined in terms of personal health literacy, which is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Before now, the way nationally we had talked about health literacy was, does Anita know when she's supposed to do what she's supposed to do? And if I don't, they'll just say, well, Anita has low health literacy and it's on her. She better get herself literate and get on with the work of getting herself healthy, right? We know that that doesn't work. Based on your work, you know communities who suffer from different challenges, even if we were to think about the elderly, right? They may know what they're supposed to do, but do they have the capacity to get themselves from wherever they live today over to the other side of town to go see the doctor that they're supposed to do? And then when they're done with that, go back and get their medications, etc. So it's not necessarily a gap in knowledge. It's frequently a gap in capacity to be able to do it because of barriers that exist, right? And so in the original version, we never talked about organizational health literacy. We are now talking about it in this new and broader and more informed definition. Organizational health literacy talks about, does the organization equitably enable individuals to find and understand and use? So it's not just what I know. Am I able to use the knowledge that I have, right? It's no good me having the best, I'm just going to use this as the best laptop in the world if nobody showed me how to plug it in and how to do other things, right? Even if we're going to say you can have a digital meeting or a digital doctor's visit, if you don't have the tools or you don't know how to work it, it doesn't work, right? So that is what organizational health literacy means. So we have the definitions. Here in our work that we've done together, we've also outlined the importance of personal health literacy, right? And personal health literacy is how effective health and other health organizational professionals can communicate with and support individuals and communities, right? So it's no good, if Anita were a doctor and she knew all of this stuff and she's a neurosurgeon, if I don't speak to somebody in a way that they understand what I mean and what I intend to mean, and they can't follow instructions, it's almost as if I didn't speak. In fact, what I might do instead is intimidate them about their lack of knowledge. So I need, as a professional, to approach everybody with a strong level of humility, right? And then understand from them and speak to them in a simplified language, not because they are simple or simplistic or raise my voice in the way I speak with them, but really to understand it, especially when people are ill, regardless of how educated they are, they actually need some help. So we're going to go into the next piece and ask the question, given that this is the definition of personal health literacy, from what you have heard me discuss, what do you think are some reasons individuals have a hard time finding, understanding, and using information and services to make health-related decisions? And I think we've asked you, go on to the next slide. So this is a question related to organizational health literacy. How do you think organizations can help individuals find, understand, and use health information? That's great. Let's go on. I think I probably need to speed up this process a little bit, but I really am enjoying the conversation more than anything else. So we have professional health literacy. What do you think professionals can communicate with individuals in terms of access, understanding, etc.? What do you think is the work of a professional? And here, I want to underscore, we're not talking narrowly about healthcare professionals, nurses and doctors and those kinds of folks. We're talking about professionals generally, people in public health. What is the role of a professional? Because all of you, many of you on this call are professionals, right? You may not be a healthcare professional, but you are a nonprofit professional. You are some kind of professional somewhere along. Your role is critical. What is your role? And how can you support this work? How do you support individuals and communities? Because we know different people have different levels, and lack of ability to speak and communicate in English does not make someone illiterate, right? It, even people who speak English may at some point in their careers or some stage in their lives need help and support. All of us at some stage will need it. So that's what we want to do. So I'm going to go to the next. So some of the things, especially when we're talking about organizational health literacy, is this idea of health literacy universal precautions. So we can go to, and we have a list there of a toolkit and the second edition and what that looks like. What we do know that is many of the resources that are currently out there really are related to traditional health serving organizations. I mean, even in terms of the definition of health literacy, as they have changed it, and they've known for some time that the original definition was not sufficient, we are now in a situation where we have precautions, but they've not necessarily written for non-health serving traditional healthcare organizations. But there is some translation that could happen. So health literacy universal precautions are aimed at simplifying communications with and confirming comprehension for all patients so that the risk of communication is minimized. Making medical office environments and healthcare systems easier to navigate, and supporting patients' efforts to improve their health. One of the, and I did not include it here, one of the things that when I've read the literature in terms of particularly the old definition of health literacy, when we used to say somebody has low health literacy or no health literacy, one set of research said, well, in fact, when you measure that, you're actually measuring more about the complexity of the healthcare organization than people's actual literacy. So you may have you may speak English fluently, but when you read what looks like sense. It may look like mumbo jumbo because it's been written by, somebody who is talking about something that is way off the charts. They may be a neurosurgeon, but it doesn't translate into what ordinary people talk about, right? So they may be jargon, they may be phrases, they may be those kinds of things that are not helpful. So we have seen things that talk about the attributes of the 10 essential attributes of a literate healthcare organization. Again, this is about healthcare organizations, and we've listed 5 here. We're going to share some of these. I think we can share the slides. We've got the access to where it is. But this could be our jumping off point. I'll just read the first 2. Has leadership that makes health literacy integral to its mission, structure, and operations. That means, does your organization really not just apply lip service to the notion of health literacy, but are you building it into your operations? And is it a point of pride for your organization in terms of how you do your work? Does your organization integrate health literacy into planning, evaluation measures, patient safety, and quality improvement? Those are just some examples. Now, all of these are referring to healthcare organizations, and some of these 10, and the next 10 are on the next page, may or may not readily translate to a non-healthcare organization that the majority of you are. But there is some of it that can translate in terms of best practices, etc. And I think that is the work that is ahead of us in the next several months. Okay, using health literacy strategies in interpersonal communications and confirming understanding along all points in contact. So when Brenton is speaking to folks about jobs or how they could get a job and where they ought to go and things like that, he needs to ensure and double check that folks understand what he's saying. It's no point him kind of talking at the 50,000-foot level and giving them a long list of places. And when you look at the list, it's not places that they could readily access, or it's out of the city or somewhere else, right? So that's the kind of thing that we mean, that we could translate them to your actual working circumstance. So that's some of what we're talking about. When we're talking, and what I've done here in this triangle is really put the 3 different audiences in the triangle with individuals at the top, right? Regardless of whether you're a healthcare organization or a non-healthcare organization, individuals are the people that you are reaching, individuals and communities. And your conversations with these individuals, regardless of what you're talking about, needs to be at the level that is appropriate to the individual that you are speaking with, right? You can't set it up and you're like, oh, we're gonna talk jargon in that location, right? So it's really all about personal health literacy and all other kinds of communication. So if professionals are talking, it's a two-way street. It's communication, right? Whether it's professionals or organizations. If we have health literacy, the organization needs to talk organizational health literacy, but when they're talking to individuals, they need to speak in the appropriate language. We may have professional health literacy, but again, we need to put it into a frame of reference that folks in that sphere can understand. And so the kind of conversations between professionals and organizations almost always is distinctly different than the conversation between individuals and organizations and individuals and professionals. And in fact, it is the role of organizations to ensure that their professionals who work with them are provided with the tools to effectively communicate with the individuals that they serve, right? So it's not just the organizations or it's not just the professionals, it's both working together to come up with the right strategies. And so the other thing that we need to break out, and I've hinted at it so far, is that when we're talking about organizational health literacy, we're talking about both health as well as non-health organizations. And similarly, in the professional sense, we may be talking about health professionals and non-health professionals. But all are important, and all have a unique set of skills and roles in terms of when they're speaking to individuals and communities, and what the caliber of their conversation and the content of their conversation is, and how they do that work. So I hope that has been helpful. Our next phase is going to be looking at a video, which I hope somewhat summarizes, but we'll have a debrief after. And I'm going to ask Kimmy to share the video with us.
Give me 1 second. Let me share my screen.
And the video is 2 minutes long. And here we go.
Attaining health literacy is an overarching goal of Healthy People 2030, a recognition that health literacy is key to achieving all of Healthy People 2030's objectives. Health literacy is about people being able to find, understand, and use health information and services. Health information is often difficult to understand. Our health system is complex. However, we can make it easier. Here are 5 things to know about health literacy. First, organizations and professionals can improve their health literacy by using proven strategies, like answering questions in simple, non-medical language and developing and testing written materials with the audience they want to reach. Second, universal health literacy approaches benefit everyone. Vulnerable people like older adults, people who have difficulty reading and using numbers, or people who are not fluent in English face the biggest challenges. But anyone can have trouble understanding health information. If we act as though anyone is at risk of misunderstanding information, everyone is better off. Third, providers can use health literacy strategies to encourage people to take part in decisions about testing, treatment, and procedures. This lets people make healthcare decisions that fit their values, goals, preferences, and circumstances. Fourth, clear communication between providers and patients improves health literacy, particularly if providers take the time to listen with respect and make information easy to understand. Checking to make sure patients understand the information is also important to ensure patients are informed. Fifth, being health literate will help people make informed decisions and take actions to improve their health. Being health literate can help people achieve their goals, whether that is trying to manage a chronic condition, engage in a healthy lifestyle, or take precautions to avoid getting sick. To learn more about how you can improve health literacy, visit health.gov/health-literacy.
All right, so what we're going to do is a little debrief on the video. Having watched the video, what strikes you? In the same process, either unmute or type in the chat. To the next question. Do you see yourselves in the video? And if so, what made you see yourself? To the next one. Did you see or do you see your organization? And if you did not, why not? I'm going to add a twist to that. If you didn't see your organization, why not? In the clock. So I'm going to go to the next one because I think that that was a kind of a setup in some respects for what we're going to talk about next. Health literacy and non-health partners, which most of you are. What is the role of health literate? What is the role of a health literate non-health organization, right? So I would love us to discuss and compare and contrast. How do you see your role and the role of your organization when thinking about health literacy? And how do we have this discussion? And I'm opening the floor a little bit to have this discussion about the difference between some things that are the same and some things that may be different for a healthcare organization versus a non-healthcare organization. What does that look like? Okay. All right. In the interest of time, I am going to go to the next slide, which really talks about, some of this will look familiar to you. because you've seen the journal, you've seen the Living Well website, you've also worked together on Link U, right? So you will recall that when we started this process, we talked about the unique role that each of our collaborating partners, most of you are non-health serving, as this idea of a bridge. And what we really wanted to do was really talk about the fact that you are the bridge. And we have a little note, we have an asterisk that says, we're still building this process as we go forward, but you're actually doing the work, right? You are the resource that serves as the bridge. We've recently added La Clinica to our working groups. They are our first, what we would call traditional health serving organization, and they have a unique scope of work to think about a toolkit that would be the other end of the bridge. But we started with the notion that community-based organizations who are non-health, particularly those that have a unique and trusted relationship with their communities, are our starting point. Because we have hospitals, we have more resources in terms of healthcare delivery in this city than many other cities in America. And yet we are still not connecting in the way that we should. And so this particular project, right, and most people just point their fingers at communities and communities that have less good outcomes and think about it as quote unquote their fault, that they are not going to the doctor, they are not going where they should. And I think we and you recognize that there is a critical role as a bridge that you guys bring to the table. You not only translate for us when we've asked you, oh, take a look at this sheet. Does this work? And you give us feedback and we improve it, right? So you are helping us as a public health agency, but an important part of your role is your interpreting and being the translator. And I don't mean kind of language translator, but sometimes that is what you do. But the translator for us as to how to do a better job. Brenton talked earlier about going out and sitting in community and asking them what works. Part of what we're doing with working with you is asking you what works and figuring out together what works. And I think the word, it'll come up in the next slide, the idea of co-creating. So we are co-creating and filling a gap that exists across the country. So we know that you have an important role to play, but there are no resources out there like the 10 attributes of a non-health serving organization in terms of health literacy. It doesn't exist, at least not yet. But we are collaborating to work together to build that. And so I'm going to go to the next. So your role, we are not asking non-health organizations to become doctors and nurses. You may be important in linking people to preventive care. You may be important to linking people where they can go to understand their health insurance benefit. You naturally connect people to resources already. We listed all of them at the beginning, remember? The social determinants of health. So you're already doing the work. You are formally connected to your communities and critical people in the folks that you serve. You're already serving them. What we are leveraging is your trusted relationship to help improve the bridge and enhance the communication. That is a critical role as we try to serve this gap that we continue to see. And we have to do something differently if we are expecting a different result. So with that, we're really talking about the work that we're especially going to do in these last several months of this grant. When you first started on the health literacy grant, you were fully engaged in pandemic and getting people connected to getting their immunizations and vaccines, right? So what you've learned by actively doing that is that people need some hand-holding along the way. What we're going to do in the next several months is distill that learning for the purpose of co-creating a non-health organizational health literacy model. And so we're really exploring the role of health literate non-health CBO organizations as the basis for how we're going to do that. You are critical to our collective success in solving the systemic problems that we have of being able to communicate to a whole lot of folks where we were successful during the pandemic, but a whole lot of others where we were less than successful. And you were actually doing the work in the community during the pandemic of connecting people to food and resources, etc. We added on for you how to connect and help us distribute vaccine. But that was not to make you into health serving organizations, but so much as to leverage your knowledge and trust in the community. And that's really what we want to leverage in our distillation of learning going forward. So I'm going to share the last slide, which is about what we call what is our goal and what is coming soon, is this co-creating this organizational health literacy for non-health community-based organizations, right? So while FQHCs are community-based organizations, they are fully in the business of delivering health. They have work to do in terms of organizational health literacy. But by the same token, as bridge organizations, you are critical to being that bridge from community to them. So that's my last slide.